We're going to talk today about the anterior cruciate ligament. The objectives of this talk are to appreciate and understand the fundamental differences between ligaments and tendons, their anatomy, composition, and function of the ACL, MRI appearance of the intact ACL, MRI appearance of the compromised ACL, and the signs of ACL injury, primary and secondary, and then a new measurement that we devised or discovered. And there's a discussion of that which I believe will be extremely helpful. The ligaments and tendons have some common features. Both of them are composed of collagen fibrils which are tightly packed and highly oriented. But their differences lie in their anatomy. Tendons are usually in the form of cords, while ligaments are layered. Ligaments have sensory nerves which serve a proprioceptive function, helping in initiating protective reflexes which are critical to all joints, particularly though to the knee, which is the largest and possibly the least stable of the joints in the body. Ligaments are responsible for stability, and they guide the movement of one articular surface over the other. We have some more fundamentals, which these facts are very, very important to kind of put in the back of your mind, so that when you're looking at any joint or any particular ligament, you should be aware of this. And why should you be aware of this? Because most radiologists tend to find or document findings, but they may have very little significance to the orthopedic surgeon. Since we serve the orthopedic surgeon in the diagnosis of disease and management of the disease process, it is important for us to know these fundamentals. What do ligaments do? They guide the joint. They stabilize the joint, and they prevent abnormal or excessive movement. Restraints to movement are primary or secondary. And the primary ones are where the ligament in question is responsible for preventing abnormal or excessive movement. The secondary restraints are the ones that associatedly help the primary restraint. So when the primary is injured or gone, then the secondary comes into place and provides some degree of protection for the joint. Solitary injuries have been reported in ligaments, but as Resnick et al. Say, there is no ligament that stands alone. So when we see a solitary injury, we must make it a point to look for secondary structures which may be involved. Also, please make a careful search to isolate avulsion fractures. Anatomic features which place the ligaments at risk for injury are the following. Please pay close attention to these features. If a ligament passes through a tunnel, a notch, or a constricted area, it's more susceptible to injury, and the injury is seen most commonly at the bottleneck. If the ligament is subjected to a high tensile strength, it's susceptible to injury. If the ligament rubs against a rough surface, naturally in normal people who have not injured their joints, you don't expect to see a rough surface. However, if there is injury to the bone or to the cartilage, a rough surface is provided which can cause attrition of the ligament in question and produce ligamentous injury. Now we're going to talk a little bit about the anterior cruciate ligament anatomy. The ACL arises from the posterior medial aspect of the lateral femoral condyle. This attachment is on the posterior part of the medial surface of the lateral femoral condyle, posterior to the longitudinal axis of the femoral shaft. The reason this is really important is when we start paying attention to the function of the anterior cruciate ligament, we will understand that when it is posterior to the longitudinal axis, it is able to do its function in a remarkably efficient fashion. The tibial attachment is in a fossa in front of and lateral to the anterior spine in the intercondylar area and on the articular surface of the tibia. This tibial attachment is a very wide area, as you can see. It is 11 millimeters wide and 17 millimeters in the anterior-posterior direction. So what does it say? What it actually says is the anterior cruciate ligament starts out with a narrow origin and fans out to its insertion where it is wider. Semantically speaking, ligaments don't have origins and insertions, they have attachments. And the attachments are important because the transition from the cartilage. First it goes from the collagen fibrils to fibrocartilage and ultimately to the bone, and these are so seamless that the bone to which the attachment occurs can actually be avulsed, and we have to look for this as well. Now the ACL is described as having two bundles, a small anterior medial and a large posterior lateral. The posterior lateral bundle becomes taut in extension, while the anterior medial bundle becomes taut in flexion. Some variability for the femoral origin of these bundles is known. Now in the frontal plane, the anterior medial bundle is located at 10:30 in the clock position. The posterior lateral bundle arises at 9:30 position. The anterior medial bundle is the primary restraint against anterior translation of the tibia on the femur. The posterior lateral bundle stabilizes the knee near full extension against rotatory loads. Rupture of the separate bundles produces different clinical signs, such as the anterior drawer sign or the Lachman sign, respectively. What kind of sequences do we generally tend to use? We use spin echo and or fast spin echo MRI, which is the most widely used method to assess the ACL. Using a fat suppression sequence allows the evaluation of fluid, edema, intrasubstance injury with a greater degree of confidence. A long TE sequence can be used to avoid the magic angle issue, which we will discuss presently. The best plane for analysis of the integrity of the ACL is the sagittal. Combined analysis of orthogonal plane increases the sensitivity of the test from 94 to 98% and specificity from 84 to 94%. Now the MRI appearance of the intact ACL. The intact ACL is seen on the sagittal images as a low signal intensity band. You'll notice that this is low signal intensity in the proximal portion of the ACL. But it then gets to develop a high signal intensity as it comes lower. And you'll also find that the best image for evaluation of the ACL is one where the intercondylar roof is seen as a low signal intensity line. This is the intercondylar roof. Volume averaging with the femoral condyle can provide a pitfall. Now the normal ACL forms a 45-degree angle to the long axis of the tibia. So if this is the long axis of the tibia, you'll note that here the ACL is forming a 45-degree angle. The inferior portion of the ACL, as I mentioned earlier, has increased intrasubstance signal intensity at the tibial insertion due to fat, which is incorporated in the bundles of the ACL. With the routine 3 to 4 millimeter slice thickness and with the knee rotated externally at 15 to 20 degrees, ACL is visualized on 1 or 2 consecutive sagittal images. Here is a coronal series of sections of the ACL. I've put arrows so that you can see where exactly the ACL is starting. So proximally, the ACL is a very thin, low signal intensity band paralleling the medial aspect of the lateral femoral condyle. In a more anteriorly positioned coronal image, you can see that the ACL starts to curve towards the tibial spine. And finally, it fans out distally to insert on the tibia. Here it shows an increased signal intensity. Now, what about the axial images? The cephalic images show the ACL to be a very low intensity object, which is oval in shape, hugging the medial aspect of the lateral femoral condyle. This hugging was also seen on the coronal images that we looked at. Proceeding distally, the ACL elongates to assume an oblique configuration. And additionally, the signal intensity in the ACL, as we mentioned earlier, increases as it approaches the tibial insertion. Raymer et al. Did a very good discussion of ACL injury, which I would recommend you read. It was in the Radiographics, Volume 12, 901 to 915. Although the ACL disruption is one of the most common ligamentous injuries, most are actually missed in clinical examination. Why is that? Because the patient is guarding, because there is effusion, there is pain, which precludes a good examination of the ACL. So this is where we as radiologists provide most value to the orthopedic surgeon. An estimated 200,000 ACLs injuries occur annually in the United States, with approximately 95,000 ACL tears. Approximately 100,000 ACL reconstructions are performed in the United States each year. I must caution you that we are not going to be talking about the repaired ACL. We're just talking about ACL injuries. The anterior cruciate ligament is one of the most frequently disrupted and injured structures in the knee. They're injured in high-impact accidents or sports such as soccer, skiing, football, etc. And they're also injured in non-impact or low-impact occurrences, activities involving deceleration, twisting, and jumping. Now, this is clinical grading of ligamentous injury. I have thrown this out so that you can see what the grading is. Are these of importance? Not really, because grade 1 or grade 2 or grade 3 can be masked so that a grade 1 may appear as a grade 2 or vice versa, and the same thing with grade 3. The thing with grade 3 also is that there is significant instability of the joint. However, if the patient is guarding and the muscles are taut, you're not going to be able to elicit instability of the joint unless the patient is put under anesthesia. There is acute pain which may resolve later, but this is associated with tears which are macroscopic. 40% of the ligamentous injuries of the knee involve the ACL alone. As you will remember, I had said to you that Resnick et al. In their internal derangements claim that isolated injuries are really uncommon, and there may be microscopic injuries which you don't see until considerably after the initial event. 35% of the injuries are injured in combination with other ligamentous disruption, especially the medial collateral ligament. About 60 to 75% of acute hemarthrosis are associated with ACL injuries. When the knee approaches full extension or is flexed less than 50 degrees, the force vector of the patellar tendon is oriented in an anterior direction. In this situation, the quadriceps produces an anteriorly directed force on the proximal tibia, resulting in an anterior translation of the tibia with respect to the femur. Now, remember when I was talking about a higher susceptibility to injury for different ligaments, I had said high tensile strength and then high incidence of injury with associated muscles producing an oppositely directed force. Now, in this situation, the quadriceps produces an anteriorly directed force on the proximal tibia, which results in the anterior translation of the tibia with respect to the femur. This is normally resisted by the anterior cruciate ligament. If the quadriceps muscle contraction is of sufficient magnitude, we get a disruption or injury to the anterior cruciate ligament. When you're looking at the anterior cruciate ligament injury, tears of 1/4 or less of the substance of the ACL are accompanied with favorable outcomes clinically. So it is critical for us to be able to tell the orthopedic surgeons how much of the substance of the ACL is injured. On MRI, increased intrasubstance signal without accompanying morphologic alteration may be a nonspecific finding or might represent ligamentous contusion without disruption. This injury may not be seen on arthroscopy. This is an important fact to remember. Increased intrasubstance signal may signify also the magic angle effect. We can avoid this by using long TE sequences. Hence, T2-weighted images may prove to be superior to GRE imaging. There is a very nice graphic from a table from radiographics which shows you where there is primary resistance to different kinds of injuries. This is a busy slide, but I have outlined for you where the ACL is involved, either as a secondary or as a primary. It is only when there is external rotation where the femur is fixed that the ACL is not injured. For everything else, you can expect to see ACL injury, which accounts for the fact that the ACL injury is the most common injury to the knee, ligamentous injury to the knee. Now, MRI is the gold standard for establishing diagnosis of ACL injury non-invasively. This means we look at the MR and compare it with clinical findings. When compared with imaging on lower field strength MR scanners, the 3 Tesla turbo spin echo MRI has shown increased sensitivity in diagnosing musculoskeletal pathology. In order to establish the MRI diagnosis of ACL rupture, a whole constellation of signs is employed. The primary signs provide unequivocal evidence of tear. The secondary signs supply additional support for the diagnosis, and as we'll see presently, the primary signs are not always reliable. Simply stated, the primary signs don't always work. So that's when secondary signs come into play. And we need to be aware of what these secondary signs are. We have to ascertain first how reliable these secondary signs are, how specific, how sensitive, and what are the conditions in which the secondary signs may not work at all. Please remember that when we look at primary or secondary signs, we're comparing it with gold standard, which may be arthroscopy or actual evaluation of the ACL injury with arthrotomy. Two major direct primary MR findings of the evaluation of an abnormal ACL are changes in its morphology. If you will recall from the earlier signs or earlier slides, the changes in morphology will show the disruption of the fibers. So when it is nice and taut and forms a beautiful straight line going down to form a 45-degree angle with the tibia, that's normal morphology. When it's undulant or appears relaxed or appears buckled or is actually broken across, there's a change in the morphology. Changes in its signal intensity are an important thing to look at. And as I said earlier, signal intensity can change because of the magic angle effect. Another caveat is chronic or long-standing tears may not show abnormalities in signal intensity in the ACL remnants, and the scar itself may produce low signal intensity linear structure, which, unless we are particularly careful, we may not be able to call an ACL injury. Additional abnormalities which are observed in the ACL are a change in its course. We talked about that. Sagging of the ligament, and then where the ACL no longer follows the contour of the intercondylar roof, tending to become parallel to the tibial surface. These are all primary signs of ACL injury. What are the pitfalls? Discontinuity of the fascicles. ACL disruption may involve one or both of the bundles. If only one bundle is involved, an erroneous interpretation could be made because a few fibers may be left intact, which would add to the difficulty in diagnosis. Overlying hemorrhage and surrounding soft tissue injury could obscure the ACL tear. Increased signal intensity, which is elevated signal, is interpreted as injury or sprain. The oblique course of the intact ACL can produce increased signal, as I told you, with the magic angle phenomenon. Some more pitfalls. Increased signal may be due to degenerative change. Partial volume averaging with the adjacent femoral condyle can also pose a pitfall. Periligamentous fat can produce increased signal intensity. Angulation or bowing may represent insufficiency rather than a tear. In some chronic tears, scar tissue develops, producing adhesions of the torn ligament to the PCL, obscuring the ACL tear. This is an important point. Now, MRI of the partially torn ACL. It is important to detect a partially torn ACL since partial tears can either progress to a complete tear and predispose to instability, or might heal based on how the orthopedic surgeon treats this patient and this injury. The MRI findings include increased intrasubstance signal with intact fibers and bowing or undulating contour of a seemingly intact ACL. Indirect signs are rarely taken to be prima facie evidence of ACL tears. Robertson et al. Evaluated 22 different signs of ACL tear and gave the following 5 signs high predictive values. Actual disruption of the ACL, which we talked about. If you see a disruption, there is a fracture or a disruption or a tear of the ACL. Disruption of individual fascicles. A bone bruise in the posterior portion of the lateral tibial plateau. In our studies, we found that the bone bruise may be an associated injury rather than a secondary sign. But the caveat here is that if you see a bone bruise in the lateral tibial plateau, look for ACL tear. The fourth is the buckled posterior cruciate ligament. The fifth is a failure of the PCL line to intersect the distal femur within 5 millimeters, which actually is a measure of anterior tibial translation. Secondary signs are used to support the diagnosis of tear when the primary sign is of uncertain value or is concealed by other pathology or technical problems. These secondary signs can be classified into two groups based on one, loss of function of the ACL and resistance to tibial translation, tibial rotation, and findings of associated injury. Some of the secondary signs, such as ACL angle, the ACL Blumenstadt angle, etc., cannot be used in the presence of a torn ACL, which brings us to why we need to use the secondary sign. So what we're looking for is a chase or a better diagnostic tool. Analysis of the posterior cruciate ligament, which we had talked about a couple of weeks ago, helps in detection of ACL injury. Now, this is an analysis of the alterations of PCL as an indirect sign of ACL injury is really not a new idea. Previous authors have described changes in the PCL's curvature ratio, posterior PCL line, PCL hyperbuckling, and the PCL angle. Some authors have opined that PCL angle of less than 107 degrees has been associated with torn ACL with a sensitivity of 52%, which is pretty wretched, and specificity of 91%. Macaulay et al. Found correlations of PCL angle with partial and incomplete tears, and complete tears. With partial tears, a PCL angle of less than 105 had a sensitivity of 72 and specificity of 79. With complete tears, the measurement of the angle is less than 105 degrees and has a sensitivity of 74 and specificity of 86. Now, the purpose of studying the PCL in the presence of ACL tears is because the PCL is a very strong ligament, which we had mentioned earlier, and this actually won't tear, but its configuration will help us in detecting an ACL abnormality. I have here a diagram where the PCL angle is measured. Since the PCL angle can assume a variety of configurations, we initially define these configurations and then define the methods by which we could make replicable measurements. The PCL angle, as shown in this, is not always the best method of evaluating the PCL. We had talked about the multiple configurations of the PCL and the actual measurement of the buckling of the PCL because some authors did not take into account that the PCL angle could not be measured if the PCL assumed a multi-limbed configuration, or when the PCL is hyperbuckled, you can't measure the PCL angle. What do you do then? Then you resort to the PCL buckling angle. We evaluated 114 consecutive patients who underwent clinical exam and 3T MRI for knee injuries. Patients with prior ACL reconstruction, PCL injury, or those with ACL injury associated with fractures were excluded in order to minimize the number of variables that could impact the PCL buckling angles. The average age of the patient was 42, ranging from 18 to 63, including 53 females and 61 males. We found something which echoes what has been mentioned in the literature. The 53 females naturally have a smaller intercondylar notch than the males. So does this pose an increased incidence of, or increased exposure to injury? We believe it does, but it remains to be seen and documented. We found that the intact PCL, despite having two bundles, is seen as a low signal intensity on all the sequences. In our previous lecture, we had defined these different configurations of the PCL. The normal angle is shown in the upper row. The abnormal angle is shown on the right-hand side, also in the upper row, which is fairly easy to look at. But what do you do when it is hyperbuckled or has three limbs? We use the best fit circle method. And if it is a gentle curve, what we do is we draw tangents to the gentle curve as it goes posteriorly and come up with the angle measurement. We found that the PCL buckling angle in our whole cohort of patients ranged from 67 to 154 degrees. Where the ACL was intact, the PCL buckling angle was found to be greater than 100 degrees. Those with ACL injuries, which included tears, attenuation, scarring, consistently demonstrated PCL buckling angles of less than 100. This is an important fact to remember because ACL injuries can be masked or can be obscured. What do you do then? Then look for the PCL buckling angle. In order to determine the validity of the angle, we conducted validity and reliability tests and found this to be a very, very good method of looking at ACL injuries. The reliability of the measurement technique was examined with intra-class correlation, where there were 2 observers, and both observers showed excellent intra-observer reliability, showing that the intra-class coefficient was 0.949. In our cohort of patients, we saw 21 MRIs which showed ACL tears. The average PCL buckling angle for knees with intact ACL was found to be 126.2 degrees. The average for knees with ACL tears was 95.3 degrees. If the PCL buckling angle of over 100 degrees was used as a diagnostic test, the sensitivity was 95 degrees, and the specificity 95%, and the specificity was 95% also, which represents a significant improvement from the previous use of secondary and primary signs. How does it compare with physical findings? And what are the tests that we do? The tests that the orthopedic surgeons do are the anterior drawer test, which looks for the anterior translation, and the Lachman test, which looks for rotatory insufficiency and pivot shift test. So what we have found is consistently the PCL buckling angle was always hovering over 100 degrees. And when there was a positive test, then they fell below 100 degrees. Estimation of the PCL buckling angle, can provide great clinical value in evaluating the loss of function of the ACL as a primary stabilizer in resisting tibial translation. The presence of a PCL buckling angle lower than 100 degrees is a reliable secondary sign where clinical examination is difficult or limited because of swelling and pain, or when the ACL is obscured by injured neighboring structures. We believe that the measurement of the PCL buckling angle is of value in the workup of patients also who have had an ACL reconstruction. ACL reconstructions are difficult to evaluate on MRI, specifically with reference to signal intensity of the graft, as well as the bowing. Clinical examination may also pose problems. Establishing ACL insufficiency can be addressed on MR by measurement of the PCL buckling angle, as well as the anterior tibial translation. What have we found in addition to the PCL buckling angle? The relationship between the ACL, PCL, and the lateral tibial plateau. This is a very important point. In the presence of an ACL tear, the PCL buckling angle is highly reliable as a secondary sign. However, when it is associated with a lateral tibial plateau injury, the PCL buckling angle and the PCL angle can be normal. There is no report of this association in the literature yet, and we intend to publicize it and present it. Here is a bibliography I have prepared for you to look at to add to your reading or understanding of ACL injury. This is the end of my presentation, and if any one of you has any questions, please send them to Robin Phillip, who will be able to pass the questions on to me, and I can either chat with you or answer your questions on email. Thank you very much.